pulmonary circulation, and also the venous drainage, it is a systematic one. And second one, it is highly innervated by intercostal nerve, mean it is a painful area because it is intercostal, it is a sensory nerve, besides it is a motor one, and also we have a phrenic nerve that supply the diaphragmatic parietal pleura, and also the innervation of the mediastinum by the phrenic also, and the diaphragmatic pleura. The visceral pleura, that is, the pleura is cover the parenchyma of the lung. It is smooth, it covers both lung. It is completely separated, the left lung and the right lung, by mediastinum. The arterial supply and the venous supply of that one, it is from the pulmonary circulation. Second one here, the innervation, it is by the autonomic nerve system. It is not by the somatic one. So it is a painless, that one, it is a painful one. So any disease occur in the parietal pleura, it will be lead to the pain. And when you have any disease in the visceral pleura, it contains no pain. This is the diaphragmatic, how you can see by diagram. We see the visceral pleura, and there is parietal pleura, and the space between them, there is still a fluid, lymphatic drainage that comes from the parietal pleura, about 1.5 liters per day, have a lymphatic drainage, and it will be absorbed by the visceral pleura. It returns back to the circulation, through the pulmonary vein. And this is very important. This fluid, it leads to the facilitated the movement during the inspiration and expiration. And when there is any infected of that fluid, it leads to the inflammatory process of the pleura. Now, the two layers of these are separated, as I said, the fluid, and this is, it will be transmission. This fluid, normally it is drained about 0.25 ربع millim per kg, and this is like plasma in consistency. And the pleural fluid, it is about turnover, it is about 0.15 mol per kg per hour. Sorry. The production and absorption of the fluid indicated by the Starling forces in the parietal and visceral pleura, and it is also hydrostatic pressure and plasma oncotic pressure that it will be facilitated from the secretion and reabsorption, production and reabsorption of this by these forces, and by also it will be enhancement by capillary permeability, and the negative intrathoracic pressure, it will be enhanced the absorption of the fluid from the pleural cavity to the visceral pleura. The fluid moves via a net infiltration gradient from the parietal to the visceral pleura. The function of that fluid, it will be decrease the friction between the parietal and visceral pleura. It will be allow the opposition of the lung to the chest wall, and also to ensure coupling between the lung and chest wall and diaphragm to optimize ventilation. When you have to a deep inspiration, it will be full all the space. Now, this is the parietal pleura, and this is a pleural space, and visceral pleura, what it the action of the hydrostatic pressure and oncotic pressure, because it contains of the protein, we have oncotic pressure. This is how it will be absorbed, the amount of the fluid, how it will be absorbed. Now, a pneumothorax mean abnormal presence of the air within the pleural cavity. The result either in the association of parietal and visceral pleura, leading to the disruption of the lung mechanism. لما يكون عندك هنا in the space of the pleural cavity, the air, it will be lead to the collapse of the lung, and it will be lead to the mismatch between ventilation and perfusion. Lung lung, it will be compressed and reduce the lung compliance and the volume and diffusion capacity. Now, this is what we see in the diagram, how it will be occur when we have a pneumothorax. A pneumothorax means there is a collection of the air inside the pleural cavity and lead to the compress on the lung, lead to the compression of the lung, lead to the atelectasis of the lung. And by frequency, by this mechanism, it leads to the mismatch between ventilation and perfusion and lead to this leak and consequence of that pneumothorax. Now, how we can divide it of this pneumothorax? The pneumothorax can divide it either to spontaneous pneumothorax occur without any pathological one, immediately it occur, we don't know, without trauma, or maybe traumatic, either it will be by blunt injury or penetrating injury, stab wound, bullet injury, shrapnels, blast injury, whatever of the type of injury. Even in the RTA, when you have a fractures of the ribs lead to the pneumothorax, or maybe iatrogenic, that we do it accidentally when you do a central line and we puncture of the pneumothorax, or we do it in collapse as a part of treatment. Previously in pulmonary tuberculosis, we did a collapse therapy of the lung and other causes. The most important now is spontaneous one. You can divide it either primary when you have معناته أنه there is no underlying pathology. This is due to the congenital, either bullae or bleeps. تكون small bullae, multiple, either تكون unilateral or bilateral, both lung or one lung. This is occur always in the adult one, young adult who do an excessive exercise, immediately have a shortness of breath and chest pain. This lead to the rupture of one of the bullae or bleep, lead to come to your a clinic or to the emergency department as a case of the spontaneous pneumothorax. Secondary, also spontaneous, without any trauma or iatrogenic or other causes, due to the COPD, chronic obstructive pulmonary disease, or maybe due to the bronchiolitis. This is more occur in the pediatric age. In pediatric age, we can see this is in bronchiolitis, lead to the pneumothorax, or maybe due to the pneumocystic infection. This is a pneumocystic infection, and more common causes is due to the Staph aureus. Staph aureus, the most common causes of that one, or maybe due to the cystic fibrosis, either a localized cystic fibrosis only in the lung, or maybe in generalized, maybe in the kidney or in the pancreas or any part of the body. Maybe you have a cystic fibrosis, or due to the severe asthma. Severe asthma may be due to the spontaneous pneumothorax, or maybe due to the necrotizing pneumonia. Necrotizing, it will be the air production to the pleural cavity, what we call it pneumothorax. Or also maybe when you have a TB of the parenchyma, especially subpleural one, when it is a rupture one, it leads to the pneumothorax. Or maybe a cause of this one due to the congenital cyst. Congenital cyst may be either bronchogenic or cardiac cyst or enterogenic cyst or maybe teratogenic cyst. Pulmonary fibrosis. Now we can find a lot of cases due to the COVID-19 and post-complication of COVID-19, especially if this patient have underlying lung disease, it will be unfortunately developed in the future after 5 to 6 months post-COVID, may be developed of pulmonary fibrosis. Catamental pneumothorax, this is due to the circular menses, during the menstrual cycle in the female. Maybe sometimes during this menstrual period, maybe lead to the rupture of the one of the bullae or a plebe, lead to the development of the spontaneous pneumothorax. This is what we call it catemenal. Trauma, as I mentioned, either a plant or penetrating one, iatrogenic due to the paratrauma, mechanical ventilation, يعني ذلك الهاي concentration of oxygen is a risky toxic due to toxic. يعني مرات المرضى يقول لك والله يعني should be given oxygen 28 إلى 30%, maximum 32%. يقول لك والله أنا خلي على 100 حتى بلكن يستفيد المريض. This is a toxic of the oxygen. الثوراكوسنتيسيس يعني أنا اليوم دا أسحب فلويد from the pleural cavity, maybe I lead to the puncture of the lung lead to the pneumothorax, or maybe due percutaneous transthoracic lung biopsy, biopsy percutaneously, I accidentally lead to the rupture of the visceral pleural parenchyma, lead to the pneumothorax. Also on central line catheterization, cardiovascular catheterization, also maybe lead to perforation of the dome of the pleura, or maybe you have thoracotomy or thoracostomy. Thoracostomy معناته a tube, chest tube insertion. Chest tube, thoracotomy means open cut of the thorax. That we call it when you have a surgery of the lung, we call it thoracotomy. Or maybe due to the bronchopleural fistula. This is bronchopleural fistula, maybe due to the liver abscess or subdiaphragmatic abscess, or maybe due to the acute pancreatitis, and lead to the formation of inflammatory process below the diaphragm and lead to the rupture to the pleural cavity, and lead to the from the pleural cavity go to the parenchyma, lead to the what we call the bronchopleuroddiaphragmatic fistula. Or maybe due to esophageal perforation, either due to the foreign body swallowed or during a procedure of gastroscopy, maybe you have this perforation of the esophagus lead to the mediastinal pneumothorax. This is what you see in the diagram. Pulmonary plebes, it is a small one, pulmonary bullae, it is a large one, maybe it is more than 2 centimeter and above, maybe it reaches to the 10 centimeter, 15 centimeter. The plebe, it is a small one, it is about 1 to 5 millimeter in diameter. It is a multiple, that one may be single or multiple, but always in the plebe it is a multiple. A primary spontaneous pneumothorax, we call it, there is no underlying lung disease. It causes a rupture of the small plebe or bullae in the apex or the upper part of the lower lobes. It leads to the leakage of the air into the pleural cavity. 80% of these patients will be demonstrated emphysema, like change on the CT scan. أنت اليوم لما تصير عندك المريض باباتي spontaneous pneumothorax, when you inserted a chest tube, and this is inserted chest tube, immediately it will be read to expand the lung immediately. And when you insert the chest tube, what we call the tube thoracostomy, it will be immediately a relief of this stress and lead to the expansion of lung. But always you should be keeping your tube thoracostomy at least for 24 hours to 72 hours. When you decide to do a surgery, you should be not dependent on a plain chest X-ray. You should be proceed for the CT scan of the chest, because when you do a surgery on one lung, you should be exclude the other lung. It have no plebe or bullae, because if there is any plebe or bullae, when you do a thoracotomy on the affected side, and without the other side have this bleep or not during the anesthesia and on the ventilation, it leads to the rupture of that bleep, it leads to the collapse and death of the patient on the table in the theater. So when you have this procedure, you should be put a prophylactic chest tube on the normal side when you do a thoracotomy on the affected side. Most common, this one, spontaneous pneumothorax, bleep and pulla. In young adult male, always we find it, especially in tall one and in smoking and atmospheric pressure change. This is also a risk factor. Secondary spontaneous pneumothorax means there is a known underlying lung disease. The underlying disease that's cause of the rupture and air leak. This is what we said in multiple cystic. It's how it will be the bullae appear, a big one, a bullae. And it is only, you can see more than bullae in the left side of the view. And this is, we can know the pneumothorax type of it. Maybe it is a closed one, or maybe you have an open pneumothorax, or maybe you have a tension pneumothorax. Now, what is the clinical presentation? Immediately when you have this pain, pleuritic in type, and dyspneic is more common. On physical examination, if the pneumothorax is the only collapse 25% of the lung, the patient clinically have no sign and symptoms. In these cases, we can treat it conservative by only observation of this patient for 2 to 4 weeks. It will be, when you put a stethoscope, it will be a decrease in the breath sound. And when you do a percussion, there will be hyperresonance on the affected side. Sometimes, especially in COPD or asthmatic or bronchiolitis, maybe you have associated of pneumothorax with subcutaneous emphysema. Tension pneumothorax, this is very important, tension pneumothorax is a very important one. And it is different than the spontaneous one, the closed will open with tension. You should be familiarized with this one because it is a top emergent in the chest trauma and in your emergency in surgical one, in surgical department. This is a tension pneumothorax beside the cardiac tamponade. How you can know? This is always a tension pneumothorax when we have a compression trauma, either fall from height or by RTA compressed, or sometimes and in earthquake, when you have a fall of the wall on the body, it leads to the tension pneumothorax. When you have a tension pneumothorax, immediately you should be diagnosis because it need immediate immediate intervention. First of all, you see the patient in distress, have an increase in JVP, and it will have start cyanosis. And when you put your finger, it will be on the neck, it will be deviated the lung, deviated the trachea to the other side. And when do an exposure of the chest, there is no movement on affected side. And when you do a percussion, it will be high resonance on the affected side. And when you put your stethoscope, it will be completely diminished of the air entry. Immediately when you the diagnosis of this one, whatever in any place, either you are at home or at road or any part away from the medical center, immediately you do a puncture one by needle, cannula, pins, any sharp material should be inserted to deflate it. This is a life-saving. Even you can change it from this tension pneumothorax to open pneumothorax. It will be cure the patient and life-saving procedure. Immediately, where you put this cannula or needle, either you put it in the fifth intercostal space, mid-axillary line, or you can put it in the second intercostal space بالmid-clavicular line. Either in second intercostal space, mid-clavicular line, or you can put it in the fifth intercostal space, either in mid-axillary line or anterior axillary line. This is the site that we put a chest tube normally. Rarely we have also Pneumo Mediastinum. This is occur when you have a rupture of esophagus, or when we have a Ludwig angina, you took it, this is an abscess formation, retropharyngeal one, and lead to the formation of abscess and lead to the air leak, may sometimes lead to the abscess of the mediastinum. It's a serious one. Or maybe have a pneumopericardium. We have, this is what we call it, a Hammond sign. Diagnosis always established by the upright chest X-ray and PA and lateral view. Clinical, you should be put it in your mind. No need, when you have a diagnosis of tension pneumothorax, no need to send this patient for chest X-ray because you killed this patient. It needs a rapid procedure to intervention by either inserted of the needle or cannula on any sharp instrument, or if you have a facility to do a chest tube. Expiratory view of the accentuated the separation between of the parietal and visceral pleura. This is when we have a small amount of the air leak. Sometimes it is a misleading in diagnosis. When you do this procedure by expiratory view, accentuated between separation and عادة المصور الشعاع يقول لك أخذ deep breath ويأخذ لك الأشعة. هنا نقول له لا، طلع الهواء expiration وأخذ الchest X-ray. This is how it will be appear in pneumothorax. It will be appear. It will be a dark black appearance. There no bronchiovascular in the lung that you see it on the left lung. In the right lung you can see it is only absolutely black without any bronchiovascular appearance. This is also the rim of that one. The rim here also is very limited amount. We can't see it. It is very limited. This one, maybe it needed to do a conservative treatment, no need for treatment. Here in this, on your left side, this is a complete collapse of the lung. How you manage this one? The most important, you should treat the etiology, either by immediate or definite treatment management. The observation for asymptomatic patient, if there's a 25% of the lung collapse or less, should be no need to do a chest tube or anything. You should keep this patient for observation for 2 to 4 weeks. It will lead to the absorption of that one. يجي السؤال هنا why you should be observed for 2 to 4 weeks. If you remember the air content, it contains about 78% of nitrogen, 20.8 from oxygen and other compartment of the zen rare gases الموجود, either CO, CO2 or any other gases. The more affinity for hemoglobin, it is carbon monoxide, and second the oxygen, third carbon dioxide, and third one it is a nitrogen. Because of this air, it is a component, a large of the nitrogen, so it will lead to the low absorption. It takes this period 2 to 4 weeks to complete absorption of that air from the pleural cavity. This is why it will be delayed. Second, it should be, if this patient he needs an oxygen supplement, you can give an oxygen supplement. And this is a success rate of the a primary spontaneous pneumothorax by the chest tube, by the chest tube, it will be re-expanded. And aspiration or percutaneous catheter or tube thoracostomy, this is another procedure you can do it, but always you should be do a tube thoracostomy. Otherwise, I dislike to do an only aspiration or percutaneous catheter. I prefer to do a tube thoracostomy. This is the procedure how we do. It should be incomplete, sterilized, and you should be infiltrated of the area by the xylocaine, and we can do an incision in fifth intercostal space, and you should be by trocar. This is a professional one. We do it by trocar. You can do by the artery. You can cut after the skin and the muscle. You can reach to the pleural cavity. After that, you can insert it your tube. But we are the professional. We can do it by the trocar. This is the procedure. It should be always put it under water seal. Why you put it under water seal? Why you put it under water seal? Because the atmospheric pressure, it is a positive, intrathoracic cavity, a negative pressure. You should be separated between these two pressures by the water. For always, why you put it in ICD, intracostal drainage, under water seal? Because this is to stabilize the pressure between atmospheric positive and negative pressure inside the pleural cavity. Now, in spontaneous pneumothorax, Babati, as you remember, I told you should be keep it at least for 24 hours to 72 hours. Why? يعني تقول استاذ انه immediately when I insert the chest tube it will be lead to expansion the lung and the patient is disappear of all signs and symptoms. Yes, you are absolutely right. لكن احنا you should be keep it. Why? Because when there's a rupture of PLEP and pulli from the visceral pleura, it will be still leaking. It take at least 2 to 3 days to start inflammatory process. This inflammatory process due to the glue lead to adhesion of that leak. يعني مثل الصمغ. Inflammatory process تطلع لك inflammatory process. It look like glue. Then it will be this lead to a closure of that area of the leak, and this is take at least 48 to 72 hours. Sometimes the spontaneous pneumothorax it take a long time. Maybe it take 1 week or sometimes 2 weeks or 3 weeks. Second question is, when I do a surgery for a spontaneous pneumothorax in the case of the PLEP or bullae. One, when you have a recurrent pneumothorax more than twice, يعني جاني المريض أول مرة spontaneous pneumothorax due to the PLEP or bullae، سويت له chest tube، رجع لي ورا فترة شهرين 3 6 أشهر سنة، سويت له مرة ثانية chest tube، وإذا رجع لك بالمرة الثالثة it should be an indication for the thoracotomy surgery. Second, when this patient he live alone، يعني المريض يجيك عايش في مكان وحده، احتمال مرة ثانية إذا انصاب وما حد ما يجيبه it will be have an increase in mortality rate. Third one, when patient he live in away from the medical center، يعني واحد قاعد لك بريف بقرية وقاعد لك له بخيمة في صحراء باباتي. This is it should be done immediately when you have a surgery for. The fourth one, when this your job it is either diver or pilot، يعني لا أنت طيار أو غواص، لأن أنت طيار بنص الطيران مالتك باباتي وصار عندك spontaneous pneumothorax، يعني ذاك عندك 2 options، لو تنزل بالبحر لو بالصحراء. واضح؟ فit should be always in this world. Also the diver غواصي باباتي إذا إنه immediately صار عنده during diving وصار عنده rupture of the pneumothorax, it will be kill him inside the sea. For this also, you should put it in your mind. Yeah, this is an indication for to do a surgery in spontaneous pneumothorax. And always don't forget, when you do a spontaneous pneumothorax of the causes by bleep or bulla, you should be do a CT scan before the procedure. CT scan to exclude the other side, affected or non-affected. This is a tension pneumothorax. Occur when we said it is accumulation, progress accumulation of the air inside, and it will be lead to the deviation of the mediastinum to the other side, And when this deviation of the mediastinum to the other side, what will occur? ليش احنا نعتبر هذا التوب emergent? It should be dealt in 5 to 7 minutes. Otherwise, it will be lead to the mortality rate. Why? لما يصير detention pneumothorax, the accumulation of this air rapidly, lead to the kink of superior vena cava and inferior vena cava. When you have a kink of this superior vena cava and inferior vena cava, معناته أن venous drainage to the heart, it will be zero. معناته it will be lead to the low cardiac output, zero cardiac output. This is the cause of the death. So I told you should be inserted a needle or should do deflated to return back of this deviation of the superior vena cava and inferior vena cava to normal, and to return back of the venous drainage to the heart. This is why it is a top emergent. As I mentioned, the clinical presentation, you should be put it in your mind immediately. It is a severe dyspnea, tachycardia, hypotension, distended neck vein, JVP, deviation of the trachea, and impaired of venous radiation to the heart. It leads to the death. Tension pneumothorax, radiological ما تلحق تسوي radiological, لكن if you have immediately you have a Mulzian pneumothorax with a number of additional features, it will be helpful to identify of this tension pneumothorax. It will be ipsilateral increase in intercostal space. يعني انت شلون تعرف هذا المريض انه chronic lung disease لو لا؟ شوف the space between ribs. When it increase the space between the space, this is a chronic disease of the lung. Depression of the diaphragm, hemidiaphragm that is affected. شوف انه عادة the right diaphragm it will be elevated more than the left diaphragm, because the liver it will be have to reach the diaphragm till the 5th intercostal space, sometimes in the 4th intercostal space. Treatment, the compression, the method I told you about. This is a tension pneumothorax, how you can see the deviation of the mediastinum to the other side. Immediately you should be dealt. This is a needle you should be inserted باباتي. يبقى عندنا شغلة لخ باباتي. This is all the causes of that one. احنا قلنا اكو spontaneous pneumothorax, اكو قلنا closed pneumothorax, اكو open pneumothorax, اكو tension pneumothorax. We mentioned about the tension pneumothorax, spontaneous pneumothorax. This is a closed one due to the either primary or secondary or iatrogenic. يبقى the most important the open pneumothorax. What we mean in open pneumothorax, there is an open cavity يعني to the chest wall. انت يجيك مريض مضروب chest wall مالته اللانج قاعد اشوفه قدام عيونك طالع بباتي. انت قاعد في center away from the يعني specialized center، قاعد لك في قرية في ناحية او في بيت او في اي مكان بباتي، في اي مكان وجاك المريض هذا تشوف اللانج مالته طالع. This is an open pneumothorax. تشوف اللانج طالع. What you can do for this one? How you can treat this one? First of all, because an open pneumothorax, you should be changed it to the closed pneumothorax. How you can change it to the closed pneumothorax? By put a Vaseline gauze. ليش تخلي فازلين جوز؟ because it is an airtight. إذا خليت الجوز العادية الهواء يفوت ويطلع منها كالاعتيادي، لكن لما تخليك فازلين جوز to close this defect وثبت الفازلين جوز باباتي، ثبت الفازلين جوز on this defect of the lung, this defect of the chest wall, I put chest tube inside the defect. والله استاذ قال دائما انه تخلي chest tube بالنيموثوراكس بالفيث intercostal space لو بالسكين، زين هذا away from the fifth or second، لازم اخليها. يعني ليش تفتح فتحتين باباتي؟ ليش تفتح فتحتين؟ هو عندك هذا ديفكت، سد الديفكت مالتك، keep one يعني opening for the chest tube. Keep one opening for the chest tube. And after that you refer this patient to the center. يعني I will deal with this defect. Okay, I will deal with this defect. This is the most important in pneumothorax. You should be know spontaneous pneumothorax. Either it will be primary or secondary, or maybe due to the iatrogenic one, or maybe to the other causes of that one. You should be know this causes of that one, Babati. And after that, you should be know there's a closed pneumothorax. And there is no defect of the chest wall. This is due to the slow leaking from the visceral pleura inside the pleural cavity, and this is slow accumulation. If it is air inside the pleural cavity only compress 25% of the lung, you can treat it conservative by observation, no need for any intervention. If it is more than 25%, it may be need to do tube thoracostomy. An open pneumothorax, you should be closed this defect by Vaseline goes and inserted the tube in the defect itself and send this patient to the specialized center to deal it. Tension pneumothorax, this is a very important. You should be differentiated between cardiac tamponade and tension pneumothorax due to the, first of all, type of trauma. Second, when you do an examination, it will be have both of them increased JVP, but here it will be deviation of the trachea in cardiac tamponade. The trachea will be central. Here it is a limitation of movement of lung, and the tamponade it will remove the lung. There is an hyper-resonance in the tension pneumothorax. In cardiac tamponade, there is no equally, it will be bilaterally. When you put your stethoscope, it will be diminished in artery, and the cardiac tamponade. In cardiac tamponade, it will be in equal air entry, but it have a muffled heart sound, hypotension, tachycardia.